Before you even start or attempt to do a Kegel, you want to know what state your pelvic floor is in. What do most people do when they can't eliminate? They push and they strain. And when they do that, they actually activate the pelvic floor even more. If we perceive danger, a threat, stress, whether it's real or perceived, right? A threat that's coming in is that these muscles will go into a guarding protective mode. The pelvic floor is part of the inner core. 25% of our young female athletes under the age of 25 are leaking.
That's crazy.
Mind-blowing to me.
That's crazy.
And you know that's underreported, right? Just like all the stats are.
Because they're not talking to anybody about it.
Every woman over age of 40, number one, should have a vibrator. By the way, I want to have better sex. We're going to go after your foot. You can hack your pelvic floor by stimulating your vagus nerve and giving that love.
Welcome back to the Rena Malik MD podcast. I'm your host, Dr. Rena Malik, urologist and pelvic surgeon. Today, our guest is Dr. Julie Sarton. Dr. Julie Sarton is one of the nation's foremost experts on the pelvic floor. She founded her practice, Sarton Physical Therapy, in 2011, and it's the only clinic in California and maybe even in the United States with 4 board-certified physical therapists. Prior to opening her practice, Julie founded and served as the director of the pelvic floor physical therapy program at the University of California, Irvine. She was also an assistant clinical professor at UCI. She is a renowned lecturer who is often invited to speak for universities and major medical societies and institutions. Today, we talked about how to do a Kegel exercise and how Kegels are not the only exercise that helps the pelvic floor. We talked about the 5 major functions of the pelvic floor and what are some signs you may need a pelvic floor physical therapist. We discussed the issue of having a contracted or high tone pelvic floor and how that can create a number of problems throughout your body, including symptoms with urination, defecation, back pain, and sexual problems. We discussed how hormones affect the pelvic floor, what to expect when you see a pelvic floor physical therapist, and why sometimes it doesn't work. We even created a pelvic floor day for you to incorporate in your workout schedule to maintain your pelvic floor health. We hope you enjoy this episode. Thank you so much, Julie, for joining us. I am just so excited to have you. This conversation is going to be so good.
I am so excited to be here. Let's dive in.
Yes. Let's start with, this is the thing. I think Kegels have had the best marketing in the entire world. Everyone knows that there's Kegels and there's some sort of exercise that we need to do. But what is a Kegel and what does that mean in terms of pelvic floor?
Okay, great question. So Kegel, you can pronounce it either way, right? It is a pelvic floor muscle contraction. So Dr. Kegel, way back when, coined this when you actually did a voluntary contraction of the pelvic floor, particularly the levator ani muscles, right? So there's really 2 parts to it. There's a squeeze and a lift if you do it correctly. So pelvic floor PT kind of emerged out of this era of we're going to help treat people who have incontinence. And so we're going to teach Kegels or Kegels. But what's so fascinating is that 80% of the patients that we treat, we actually will do the opposite with. My clinic happens to specialize with a lot of pelvic pain. So we get patients that come in that are already in a Kegel state. So, and they're walking around in that state due to various, reasons. But I think when people start learning about pelvic floor, they'll think, well, I should just start firing off 50 Kegels a day and I'm going to strengthen and that's going to solve my problem, regardless of what the problem is. But so I think, the narrative has definitely changed. And a message I'd love to share is before you even start or attempt to do a Kegel, you want to know what state your pelvic floor is in. Is it lengthened? Is it in a healthy state? Or is it in a shortened, what we call hypertonic or overactive state?
Yes, these are great points. Before we get into more about what that means, let's just do a basic anatomy of the pelvic floor. What is a pelvic floor and what are the different components of it and what is the function of the pelvic floor?
Such great questions. I love it. Okay, so as I explain the anatomy, I'm actually going to use a model, a 3D model. This happens to be a female model. Okay, men, you have the same exact musculature. The genitalia is different. So this is a group of skeletal muscles. So they are like every other skeletal muscle in our body, just like your bicep, hamstring, but there's some properties that make them a little bit different and unique. Okay, so before we go into that, really where these muscles exist is they go from the base, the anterior part, or the front of your pelvis from the pubic bone in the female, wrap around the vaginal opening, touching into the perineum, and then coming all the way back to the base of the spine, tailbone and sacrum. There are associated muscles that we call pelvic floor friends that literally connect you hip to hip, right, with the pelvic floor muscular sling. So these muscles, there are 3 external, but a majority of them sit internally. You can develop the same kind of problem as any other muscle. So say you have, a muscle spasm, right? Or muscle weakness. The pelvic floor can present with the same type of muscular dysfunction. We'll talk about why I call these muscles the great deceiver, because so often they're missed and they're not really considered when a physician or a provider is really doing a workup, because again, we're not really trained to assess these muscles routinely, and these muscles will send referral patterns elsewhere to the body. Yes. So for example, they can create lower quadrant pain, abdominal pain, low back pain, because they manifest these referral patterns where the brain perceives the pain, but it's not coordinating with where it truly is coming from. So the muscles themselves, then, they have 5 different functions that are so important to life. And so we call them the 5 S's. The first one would be sexual functioning. So with sexual functioning, this helps with not only just your ability to have pain-free sex, but also orgasm. So for both men and women, we go back to what state is the musculature in? A healthy muscle should be elongated. If I take my bicep here, I know I can generate force if I go through my full range of motion, okay? And I actually will generate peak force right about mid-range. So with sexual functioning, because we know that the pelvic floor will play a role with orgasm, we actually need to be lengthened, and then those muscles will contract to help build with orgasm, okay, and go through that full range. Now, if somebody walks around with a pelvic floor that's short or hypertonic, maybe they're only here and they only can contract. The muscles, it's fascinating with sexual functioning, because what they'll do is they actually will help create a compression around the main vein that exits from the clitoris, right, or from the penile shaft. And so it's the dorsal vein. And so it prevents blood flow from leaving the area, which helps build with orgasm, because orgasm is a vascular response, a muscular response, a response to healthy, good nerves, and then brain too. So sexual functioning, 1, orgasm, and the other, before we leave that, is for women and men. If the muscles, again, are short too, you can have pain with sex from the muscle, actually, for example, being so shortened and contracted that it can't lengthen out. So if it's penile and vagina sex, then, or penetration, whether actually vaginal or anal, is those muscles need to be able to lengthen and accommodate, right, for whatever is going internal to really help with enjoyable pain-free sex. So sexual functioning, number 1. Number 2, stability. So these muscles will fire with every step we take, and they work with our abdominal muscles, they work with our low back muscles. And so a lot of people don't think about this role of the pelvic floor. So what will happen is if you have a problem with the abdominal wall musculature, say it's offline, not working, or even an SI joint problem here, low back dysfunction here, is that these muscles will tend to go into this overactive hypertonic state to compensate, to create stability through the entire pelvic girdle and support the lumbar spine. Stability, number 2. Number 3 is supportive. So the muscles help hold up the pelvic organs. right? So bladder, female uterus, rectum, male prostate. There's an intimate relationship with the pelvic floor and all the organs. So what we'll see is dysfunction with people who will end up having prolapse, which is descent of an organ that starts to change. And that can be not just due to pelvic floor dysfunction, but also ligamentous laxity from above, improper lifting techniques, even with athletes, breath holding, sometimes after pregnancy. So there's a huge supportive function as well. The fourth would be sphincteric. So the muscles will actually come around and they help close the urethral sphincter, and on the back they help close the external anal sphincter. So the muscles need to be able to contract really well to help us prevent leaking inappropriately when we don't want to, whether with bladder or bowel functioning. But it's at the same time, on the flip side, they have to do this. They have to release effectively, so we actually also can eliminate effectively.
Yes.
So we'll see women and men that come in with urinary hesitancy or retention or urinary urgency frequency, and that can be related to the fact that they're not emptying their bladder sufficiently, or we see it as outlet constipation on the backside. Those muscles will just put that anal canal and the rectum into a lockdown position, right? And so what do most people do when they can't eliminate? They push and they strain. And when they do that, they actually activate the pelvic floor even more. The brain starts to learn, oh, like those muscles should be active, when in reality, they should actually be lengthened and relatively quiet so we fully eliminate.
Yeah. Or they're trying to like do a little dance on the toilet and get comfortable. Or try to like, oh, if I lean this way just right, you know?
Yes.
Yeah.
And there's definitely techniques that we can use to help the system, like squatty potty, for example, right?
Love the squatty potty. So you saw I have one in my bathroom.
I know. I love it. It's so great. So knees need to be higher than the hips, essentially, to help the pelvic floor lengthen and relax. So, and then it's a question we ask a lot of patients that come in to see us is, tell us how you're urinating. Hey, by the way, do you push your pee out? And when I first started treating, I didn't ask that for a long time, but you'd be surprised how many people will use what we call Valsalva void, and they bear down and they push with urination and defecation. So again, like that gets them into a cycle.
Yeah. And they don't even know that that's abnormal.
No, right. Yeah. They're like, I thought everyone did that. Right.
Yeah. And that's a long story but there's no education, right? So they don't know.
Fifth thing is called a sump pump, which a lot of people are like, what is that? So essentially the muscles, again, need to go, when we start talking, like through their full range of motion, because when they actually will contract effectively, they help push different fluids, and that could be or structures, through the pelvis. So lymphatics, for example, right? There's an intimate relationship. So we have a lot of lymph nodes that exist in the pelvis, and the vasculature coming also up through the pelvis, like in terms of venous congestion or pelvic congestion. Like those muscles need to move to pump. The action of the muscle is actually pumping that fluid then through the pelvis, up and down. Yes. And that helps with detox and elimination too.
That's great. When was the last time a doctor spent an hour with you and truly focused on your goals? And when was the last time you left feeling like you really understood what was going on with your body and had a clear plan of what was going to happen next? At my practice, Rena Malik, MD, I aim to do just that. I specialize in sexual dysfunction, bladder health, hormone health, and pelvic pain for all people. And I want to revolutionize how we take care of patients. I want to really get to know each and every one of you. That's why at my practice, when you come to see me, I'm 100% present with you for an entire hour. And after you leave, if you forgot to ask me something or need clarification on something we talked about, don't worry. I'll respond to your issues and questions quickly through our secure messaging portal without any additional costs. Just go to www.renamalikmd.com/appointments and schedule your visit today. We see patients in Irvine and Beverly Hills, California, and virtually for patients from California, Florida, Illinois, Maryland, New York, New Jersey, and Virginia. If you aren't located in these states, consider making an educational visit where we can talk about your conditions generally, but I can't diagnose or treat you. I can't wait to see you. Let's go through all of these, but I want to go back to something you said earlier. You said it depends on what state your pelvic floor is in. So how can a person who's sitting at home, who maybe is really nervous about going to the pelvic floor physical therapist, doesn't have access to a high quality pelvic floor physical therapist, and we can talk about that later, but how can they determine what the natural state of their pelvic floor is?
Okay, that's such a good question. So let me walk you through. And even before I do that, though, my goal, honestly, is someday before I die, is that I would love to see that this becomes so dang standard of care that every person and human will know how to do this, will know how to assess, and every, honestly, physician will include this as part of their exam. Right.
Yes.
So we're not chasing it. We're actually being proactive, and we can catch things that are just subclinically there, but there's dysfunction that maybe is already setting in, and then it won't take a long time to get rid of it.
You know, on that point, in France, every postpartum woman, I don't know if it still happens, but a while back, at least I read that everyone gets physical therapy.
Yes. Standard of care.
And that's a point in time. The reason they do this is it's a point in time where many women develop pelvic floor dysfunction. And so they're sort of preventative. Also, women develop weakness of the pelvic floor, but that would be amazing. It's a much smaller country than the US, so more feasible. But ultimately, they have invested in the care of at least their postpartum women. And that's amazing. And I think we need to think about that in a bigger scale, for sure.
100%. I agree. And through various stages of life, right?
Yes.
So, I mean, that's a wonderful supporting through pregnancy. Same thing should be happening for every woman that's perimenopausal to menopause. Like there's just these key times in life that it's going to be challenged a little bit more. So,
or every kid with constipation or every.
Yes, exactly. Yes.
Yes.
So how do you know if your pelvic floor is dysfunctional? So we want it in this ideal lengthened state at rest. We don't want to be walking around with it hypertonic, and we don't want it like all lax and loosey-goosey. So an easy way that you can test this is you actually can feel with your fingers on the perineum. So I'm going to show you again with the female model. So the perineum is the area right here that comes off of each sitting bone underneath the vulva and in between the external anal sphincter, or it would be under the scrotum. So when this area...
The taint, guys. The taint.
The taint.
Let's just make it simple. Yeah.
Right. Yes. So when the muscles actually are hypertonic or too overactive, there's a lot of tension here. And what you can do to see, like, okay, well, am I already there? Because if you walk around with this day in and day out, you don't know. Mm-hmm. So you can do a quick Kegel, which it means a contraction again, right? So you're going to squeeze and lift. And you're going to feel actually if there's an elevation off your finger, but more importantly, you're going to feel, does it drop back down and relax when you release that? Okay. So if number one, you feel no motion there, it's so dang, it might not just be weak, but it just may not have moved through any range of motion that's not generating any force. Okay. And then the next thing, so it's the dropping and opening that we're seeing if we can achieve. The next thing you can do on the outside too, is you can even just feel with some of these superficial muscles. If it hurts, right? And when these muscles aren't activated, and if I'm just laying down, hook lying on the bed and I feel here, or on the toilet actually is another easy place to assess your pelvic floor. If there's abnormal tension, tight bands, what we call trigger points, or pain, that's not normal, especially on the toilet, right?
Yeah.
So you can feel the integrity, you look at the contraction, you look at the ability for it to release, for it to move through range of motion. And then you listen to yourself. I've even done this in the shower too, or your body, as you palpate some of these muscles. Even you can come back off the tailbone on the outside and palpate some of the tissue here. And if you get a symptom where you're like, oh my gosh, that's my pain. Actually, I get it to my sit bone because I have a history of some pelvic floor dysfunction. And yeah, I can treat it in the shower then, by the way.
And it can reproduce any of the symptoms that are related. And we're probably going to talk about this later, but you can develop all sorts of symptoms with pelvic floor dysfunction, some which can be urgency and with urination. And that's one that you can reproduce sometimes when you feel the pelvic floor tension. So if you're like, oh my God, I got to pee, like that can also be a sign that your bladder symptoms are related to your pelvic floor. Or if you're really stressed, do it when you're stressed, because you may notice that your symptoms are only episodic. They come once in a while. So when you're stressed is probably the most likely time for those muscles to be tense. And so then do that examination of your pelvic floor muscles during the stressful time, because you may notice that if you do it when you're not stressed, you're not having any symptoms, you're like, yeah, everything's fine. But why do I keep having this problem that happens once a month, or, you know, every time I have this huge paper due, or whatever it is, right?
So that brings up such a good point too. So what makes these different than your other skeletal muscles is that they're governed by your autonomic nervous system. So exactly what you just described. So when we undergo a stressful event, particularly if there's chronic stress, right? And the sympathetic nervous system goes into overdrive, the pelvic floor actually becomes more active. And it's a common reason that we see it go into this shortened hypertonic state. So they did this really cool study. I always love telling this to patients because it really gets the buy-in that patients need to learn how to, we call it, down-regulate their nervous system. So they had women and they had them on an exam table and they did needle EMG into the pelvic floor muscles. And then they went to adjacent other muscles. And I don't know whoever signed up for this study because I would.
So what's it, just for our audience, a needle EMG is where they put a needle into the muscle and it attaches to a machine that then gives a read in the activation of the muscle, right? I described that.
Yes. Thank you. And then all they did was show a scary scene of a movie, or they asked patients to do difficult arithmetic and timed them just enough to get the nervous system like
stressed a little bit.
Like, okay, I don't want to seem dumb. Like, oh, what's the answer to this? Or, oh, you know, what's happening with the movie? And so sure enough, guess what happened? The pelvic floor muscles reacted with more activity. So we saw that, you know, that shoot up with the EMG activity, but then the adjacent muscles that they went to externally, like in the leg or the glute, they stayed quiet.
Yeah.
So it was such a good study. It was done a long time ago, but I love telling patients because here's the thing. If we perceive danger, a threat, stress, whether it's real or perceived, right? A threat that's coming in is that these muscles will go into a guarding protective mode.
Yeah. Similar to TMJ. So people will get muscle tension in their jaws and they'll grind their teeth at night and they'll wake up with headaches. And there's like literally no control over it. It's your body's stress response, right? You can't control what happens when you sleep. Like I've asked my dentist, I'm like, so will this ever be cured? And he's like, well, if you lived a stress-free life, you know, then you'll be cured, but no one does, right? So it's really interesting and really important. I want to talk about, because you mentioned do a Kegel, but so many people don't know what that is, and they don't even know what you mean by lift and squeeze. So let's talk about how to do a Kegel.
Because a lot of people love to cheat and use accessory muscles, right? So I'll always ask a patient when they first come in, I'm like, okay, show me how you do a Kegel. I don't give them any instruction. I just want to see like what technique. So a lot of people will cheat in their glutes, like glute max will squeeze together as though they have $100 bill right there and they're going to hold on to it. Okay. So, or inner thighs will pull in together.
Abdominals,
right? And breath holding like this. So truly, a Kegel is, we call it the PC muscle, the pubococcygeus, which is like the Kegel muscle. And so it's the first muscle once you just go internal with your finger. And that muscle should actually compress. Think of a 360 degree, right? So compression all the way around your finger. And then that's the squeeze, right? So it closes down the sphincter like we talked about. And then it should actually elevate as well. And then when I say elevation, I'm talking like up towards your head. So really there's two parts to this. And then the relaxation is so important that it drops and opens. So, you know, when you do that, you got to think like if people walk around already in a semi-Kegel state, that's going to also create compression from the pubic bone in the front where the muscles attach back to the tailbone, because that's where that muscle goes. Like all the muscle names tell you where they go, right? Pubis to coccyx. We don't want that. We don't want all this compression in through here. But we do want it to fire when we need it, right? When the demand is there, like, oh my gosh, I'm exercising, right? And I jumped and I don't want to have accidental leakage or cough, laugh, sneeze. I mean, all of these other activities, when intra-abdominal pressure is increased, the PC and really the whole pelvic floor, because they don't work in isolation, they contract to respond to that force from above.
Yeah. What I tell my patients typically is, so you can learn what it is for people who really have a hard time, is like if you're peeing and you stop the stream of urination, that's a Kegel. Now you don't want to do it when urinating, but you can at least learn what that muscle, like how it feels to use that muscle.
Yes.
And then I tell women, pull up and in, or you can feel like you're holding in a fart.
Yes.
Or
absolutely.
For men, you can, and that for men as well, but men, it's like the feeling where you try to lift your penis up without touching it.
I use that. I always say, okay, we're in line at the grocery store. I'm standing behind you. You have to pass gas, right? And what are you going to do? Right? You're going to do the big squeeze, right? You're going to no. You're going to do that inner squeeze. So I love that one to get the posterior the backside of the pelvic floor.
Yeah.
And then you can think of as a female. You're right. So, or male, just what you do to stop the urine flow. For women, I love, you think about like a flower with the petals closing, or like picking up like a blueberry, right? And sucking that in and bringing it to get the lift as well. We use an elevator analogy. You close the doors and now pull up to the second floor. Let's go to the roof, see what's up there, right?
That's a good one. What do you think about those pelvic floor trainers that you can buy? So for women, there's ones that you can insert into the vaginal canal, and they sort of give you some feedback in terms of how strong you are doing it or how relaxed it is. There's some that come with sort of electric stimulation. There's one for men that you sit on. And I have my thoughts, but I'd love to hear yours.
Yes, I think that there can't be a blanket prescription for everybody. And it comes back to, what state is your pelvic floor in the first place? Right. So I've had plenty of patients who have had like that overactive hypertonic pelvic floor. And like, for example, they go do like the Imsala, or they're on one of the personal trainers that, has E-stim that's like, let's wake this up and fire it. And then it can actually elicit more of that contraction state, and pain can start.
So Emsella is it uses magnetic technology to cause stimulation of the pelvic floor. And E-stim similarly uses different electric stimulation to cause quick contractions usually, right? Am I right? Quick contractions. So it's like, some people will call like an auto Kegeler, or it does it for you, so you don't have to do it yourself, which is, sounds pretty appealing to some people.
Number two, right? So if you have a healthy pelvic floor and you're like, okay, well, this is just weak and I need to do neuromuscular re-ed with this to get this system back online and fire when I need it. The problem is, again, the muscles don't work in isolation. So we're training. I mean, it's good proprioceptively if you have no idea, like, where is my pelvic floor? And a lot of people don't. But it's not functional. So meaning that, number one, that we always move as quickly as we can to get people upright, and we get the pelvic floor to fire with the abdominal wall, right? So because it does work with the deep transverse abdominis, a deep abdominal wall muscle, even the rectus, and they've done studies to show like the PC works with, the rectus abdominis, and the iliocossageus or cossageus works with the transverse abdominis. And then they also work with a muscle in the back called the multifidus. And then the fourth muscle is actually the diaphragm. So you think of this canister. These are our inner core muscles. The pelvic floor is part of the inner core. And so what we do with patients, and I think this is what makes a really great pelvic PT, is we got to figure out, number one, why did the pelvic floor go either offline or become dysfunctional, right? Is it a driver? Is it the victim of the problem? Number two, we look at movement patterns, and then we're all, okay, what is the problem for this patient in front of me, right? Is it a volleyball player, right? Or a gymnast that lands in every single dismount or like every jump, right? They're actually leaking. So if that is, we treat that patient very differently than somebody else that might come in with, like you said, urgency, frequency. And so we train specifically for the functional activity that they're after, and we start putting together like, okay, inner core is back online, now what are we going to do with outer core? And we start to look at even like, how do they walk? How do they stand? How do they sit? If I sit in a posterior tilt, just meaning like I tuck under and I sit like that 8 hours a day, I'm going to get in trouble if I do that for 6 months, a year. COVID. This is why we started seeing a lot of people in COVID, because everyone was working on their computer, on their couch, in this posterior tilt, stressed.
Yes.
Yes,
right? Absolutely. So you mentioned a victim or a source. And so I see this a lot in terms of people who have like pelvic pain or have even hip abnormalities like labral tears, or maybe one leg is shorter than the other. Yes. And then the pelvic floor becomes a victim. So let's talk about that a little bit. What does it mean? Like, what does that mean?
That means that there is an underlying driver present, and the body has been so brilliant that the pelvic floor is compensating for the original problem, right? So then the pelvic floor becomes the victim. It can become the victim from that. Can also become the victim from like an inflammatory component going on. So say if you have a patient with endometriosis, right? That's an inflammatory condition. The pelvic floor, while it can be a pain generator for somebody that has endometriosis, it's also reacting to the inflammatory component of the disease process itself. And so muscle will react in the face of inflammation. The muscle properties will start to change. So what we want to do is we want to go after also dropping, like if it's an inflammatory component, or, right, if it's a biomechanical thing, like a scoliosis, a short leg, like you said, okay, well, is it a true leg length difference? If it is, we need an insert, right? If it's an SI joint problem and that joint is so hypermobile, it's moving and it's loosey-goosey and the pelvic floor comes in to stabilize that, we got to strengthen all those supporting muscles, right? Maybe even you can't strengthen a ligament with exercise, but if they need like prolotherapy or something like that. So we go and we figure out as clinicians, like, okay, driver, victim. And if it's victim, what is the driver? What set the stage? And that I love, because then you get to put your detective hat on and it keeps me going almost 30 years later, right? Because I'm like, yay, another case, and we get to figure this out.
Yes, we are detectives, 100%. You also mentioned volleyball players and athletes sometimes are either causing themselves pelvic floor dysfunction because of certain repetitive motions or doing exercises improperly. So let's touch on what you see in terms of your practice and what you would tell people to do when they're really like, maybe they're getting scholarships for extra, for their athletic pursuits, or this is something they have to do, right? They are not just doing it for fun. They're doing it because they, this is important for their future, or they just love this one exercise. Like they love doing deadlifts and like, whatever it is. What are preventative things? And what do you see?
So to start with, it's so important. The research shows that 25% of our young female athletes under the age of 25 are leaking.
That's crazy.
Mind-blowing to me.
That's crazy.
And that's underreported, right? Just like all the stats are.
Because they're not talking to anybody about it.
They're embarrassed, right? And they're wearing panty liners. And so, for example, you could take a volleyball player, right? Or gymnasts, dancers. We treat a lot of them, not only during the sport, but also later in life, right? The athlete comes in and hopefully, and then we do a ton of education on their training program. Because if you overtrain and you keep shortening, think of dancers, ballet dancers are taught in and up with the core. Right? This is not just pelvic floor. This is like in and up. We're going to be as tall as we can, up through the head. And they're never taught to actually do the opposite. How do we lengthen? So we start identifying and changing up just the training program on, you've got to lengthen not just your pelvic floor, your hip flexors, right? Your hamstrings, right? Your inner thigh muscles, breath work becomes huge because the pelvic floor and the diaphragm have a pressure relationship. So as the diaphragm drops and really elongates, the pelvic floor does the same thing. In fact, the pelvic floor is more of a true diaphragm than a floor. So we look at breathing patterns, but we change up what they do. We work with, maybe if they're competitive, with their trainers, with their coaches, right? My daughter happens to be a volleyball player. So she's a libero. So she sits back in a squat position in an abnormal time. Like yesterday she played volleyball for her beach team at high school and then also for her club. So it was 6 hours, right, of her overtraining, right?
Yes.
And so her pelvic floor in a squat, your pelvic floor is on. In a full-blown squat, you can lengthen it, but in a partial squat, it's on, right? So hip flexors are shortened. So she has a problem with her pelvic floor, which actually refers up to her low back, which actually contributes to some of her menstrual cramp pain, her menstruation, which actually makes inserting a tampon really difficult. So I'm sorry if you're listening, my beautiful daughter.
But, you know, I mean, thankfully she has you to help her work on that.
100%. Yes.
In terms of like, so while we're talking about athletes, I think a lot of issues happen when people don't breathe, as you alluded to, because people tend to breath hold a lot.
Yes.
And so what I tell people is when you are doing the exertion, you need to exhale, right? Because so you have to, I find myself having to remind myself because sometimes you just start breathing and you realize you're off, right? You start breathing and then you're like, oh wait, I'm breathing on the relaxation instead of the exertion. So I have to like remind myself as I'm lifting heavier and heavier to do that. And particularly as you see bodybuilders or people who are doing really heavy lifting or doing a ton of crunches, right? I think I see it in those sorts of people where they could actually cause dysfunction because they're not breathing correctly.
Yes, absolutely. We see this with CrossFit a lot too. I don't know if you remember, but gosh, how many years ago was it? Maybe 5 or 6. And it was going around online because this CrossFitter female was up on stage in competition.
And she leaked.
And she was leaking, and it was like the badge of honor. And we're like, oh, all of us pelvic floor PTs were like, that's not a badge of honor. Like, you are going to be in trouble, right? If you keep doing this. And so working on re-educating the whole system. So you don't have to give up your sport, but doing it in a smarter way. That is much healthier.
Yes. And while you would think that that particular woman was leaking because her pelvic floor was weak, it was probably because her pelvic floor was too tight, as you've described. And so she was probably not relaxed enough to be able to clench her muscles when she needed to, she needed to actually lift the heavy weights. And so it's not always a blanket statement, which is, again, why it's really valuable to get evaluated. I got a question from my audience. Can you do pelvic floor exercise gym day, just like leg day? Can you do pelvic floor day in the gym?
In the gym? Yeah, that's fun. I like that idea. And so, but we're going to do a dance. We're going to lengthen. You could do a whole series of pelvic floor lengthening. Just so incredible because the spine will love it. The hips will love it. A lot of hip opening, decompression through the spine. And then you could do some strengthening. And then I always say, then end with a little bit more lengthening to make sure we're going back to that healthy natural state. And we're not going to walk around then with that hypertonic pelvic floor. So I love that idea.
So let's right now, let's come up with pelvic floor day.
Okay.
So you got your arm day, you got upper body day, you got lower body day, you got full body day. Let's add pelvic floor day.
Love that. I love it.
So let's do some lengthening exercises. What are those?
Yes. Okay. So a simple one you can do anywhere. You don't even have to get on the floor, is to go into a full blown squat. So think of peeing in the woods, that type of squat where you're low to the ground. Really, your muscles aren't doing anything. Okay. So it's a passive stretch of the pelvic floor. And you got to think of too, like, how do people in certain parts of the world go to the bathroom, right? It's brilliant. Like, because you go into a squat, full elimination. And we think we're so advanced, like with the Western toilets here, but the higher you are up on the toilet, right? The more challenged your pelvic floor is.
And, we're making them higher for elderly patients who already have other issues that make it more likely for them to be constipated. They need the squatty potty max. Like, they need it.
Yes. I'll never forget. I had this patient and she was Iranian and she went back to Iran for the summer and she was was like, oh, what am I going to do? No pelvic PT for 3 months. And I'm like, you're going to be great. She came back and her symptom was actually stinging and burning, urethral pain every time she waited. Plus, she would get some referral back, like with the tailbone, and then urgency frequency. So she was peeing more frequently. So she came back. I'm like, how'd you do? She's all, I did fantastic. I'm like, that's awesome. Tell me why you think you did so good. She goes, because I went to the bathroom like this every day. And so she dropped down into her squat. And she goes, and by the way, I didn't just get a squatty potty. She bought like a whole platform that went over her toilet because she was trying to balance on her toilet.
Yes.
I'm like, you can't fall off the toilet. So she got, it's called Nature's Platform. So literally she goes, I don't care what anyone thinks, but this is incredible for my pelvic floor health, my elimination, and my symptoms are pretty much gone.
That's great. You know, in India, that's how you use the bathroom, at least when I was younger. And so my cousins, when they immigrated from India, I remember he was so cute. He would come and he was so small and he came and he would literally squat on the toilet. He was small enough that he could like squat on the toilet like that. And that's how he would go to the bathroom. And we would think it was so funny, but it was just him like, that's how I poop. Like that's how it comes out. So, okay. How long do you do that for? How long do you hold it for? Are you doing like real squats or are you just sitting in that position?
So awesome questions. You want to think about trying to hold for about 1.5 minutes. The big thing is work with your breath. If you breath hold when you're down there, then that's a problem. So I want you to take a nice deep diaphragmatic breath in when you're in the squat, and you can exhale, and you could do a series of about like 3 breaths, and that should get you, 3 to 5 breaths through that about 90-second, and then you're up. Anytime you're walking, if you start to feel like, I've got some whether hip discomfort, back discomfort, pelvic floor pain, right? How easy is it to drop down into a squat? If you are restricted with hip motion or the heel cord is tight, you can go down against a wall and use the support of a wall. You can hold on to a nice piece of heavy furniture and use, drop down holding on to that. So that is so easy.
And make sure it's heavy. We don't want it falling on you.
Yes, yes.
So that's one exercise. Let's do a few more. What else?
Yes. So there are a lot of yoga positions actually that we'll teach patients because you can get beautiful lengthening of the pelvic floor. So there's something called Happy Baby.
I give that to all my patients. They're like, what is it? I'm like, well, let me show you.
Yes.
Let me tell you exactly what it is.
Yes.
But it's literally what you see babies do.
Right. Exactly. Yeah. Yes. And sometimes we'll give patients a modification if they really can't reach to the bottom of the foot. So it's the elbows will come just right inside the knee, and you gently come up into, we call it external rotation, and we bring the leg out, and then you push and you get this beautiful opening on both sides. If it's too hard to do both sides together, do one leg at a time. So different variations of that, but look up Happy Baby and
keep breathing.
And keep breathing. That's the other thing, right? So do those 3 to 5 breath cycles through that stretch.
Yeah.
Wonderful one. Another yoga position is child's pose that we teach all the time too. We play with position of the hip and the legs with that too, depending on, do we want to open the sitting bones in the back, right? So for more of we call it the back side of the pelvic floor, the posterior muscles need to stretch, or do we want actually more of the stretch through the front? So you can, change it up depending on that patient. And if you are like, I don't know, just do it both.
Do
right?
both.
Into both positions.
Yeah. Okay. So we've got 3 exercises, right?
Diaphragmatic breathing is another quick way to just get the pelvic floor back into like this healthier state.
So people don't know what that is. What is diaphragmatic breathing?
So our diaphragm is our primary breathing muscle, and it's up under the rib cage right in through here. And if that muscle is tight and pulled up under the ribs, the pelvic floor tends to follow it. Okay. So many people will use dysfunctional breathing patterns, and they'll use all these accessory breathing muscles through the neck. So you'll see like a lot of chest motion, and you'll see that these muscles are really tight. You can feel them. When we do a diaphragmatic breath, the belly actually not just expands, so versus chest expansion being the primary motion we see, you can still see a little bit, but the belly actually expands. And I always tell patients we want that 3-dimensionally. The rib cage expands laterally, right? So the back actually expands too. So the lowest lobe of the lung can really fill with air. So number one, it allows the pelvic floor to lengthen and drop. Number two, it gets us into the parasympathetic state, which is rest and digest. And the pelvic floor, just by being in that state, will lengthen out. And that's our state.
Yes, yes. So going back, we've got this deep, deep squat.
Yep.
We've got happy baby.
Yes.
We've got child's pose.
Yes.
And we've got diaphragmatic breathing.
Yes.
So do 3 to 5 reps of those with make sure you're exhaling and taking deep breaths throughout all of it.
Yes.
Okay. So then we're moving on to some strengthening exercises. What about those?
Okay. So strengthening. We want to bring the pelvic floor. We want to load it so it learns how to explode when we need it, right? So for strengthening, we will use it in a system. So I like to do weight bearing type of pelvic floor exercise because that's life. And again, it's working with the deep transverse abdominis. So to start, actually, I will teach patients first how to contract the deep abdominal wall without breath holding in standing. Okay. On, for example, one leg. Okay. To challenge it a little bit more. Okay. And then not locking out the knee or the hip, just with a slight knee bend and hip bend, almost like you're in a surfer position. Okay. So we can get that on. Pelvic floor should start to turn on a little bit, especially if we start to rotate. So there's like a whole progression we can move people through.
Okay.
Where do we start with everyone? It's hard to give a blanket prescription because some people can't even balance on one leg. Right. So for them, we're like, okay, toe down, right? Or okay, let's master this. Maybe, laying down hook line. Can you get those muscles on, and then can we actually extend a leg out before we go upright?
And so those muscles, how can they tell they're contracting them?
With the pelvic floor or the whole system?
Well, so the abdominal muscles are what you're sort of, you're gauging the ability of those to contract because they're going to also contract the pelvic floor is what I'm getting, right?
Yep. They're going to give overflow because again, no system works alone or no muscle really works alone.
Yeah.
So like, for example, if you want to get your deep abdominal wall on, you can feel just inside your pelvic bone in the front.
Those 2 little bones that you feel on the side. Yep.
Yes. And if you drop your fingers right inside there, you should feel as you think about getting into the tightest pair of jeans, like we're laying down on the bed and, oh my gosh, I'm going to zip the zipper and get into this tight pair of jeans is a cue, one of many cues we play with patients. And you'll feel a tensioning right under your fingers. Okay. It's subtle. It's going to be like I make a fist, like an isometric. Okay. And then I open. But it's a cue. Sometimes we'll also talk about connecting like a wire that connects from one side of inside the ASIS or that pelvic bone right in there to the other. And like you're going to bring them together this way. Okay. And you can feel a tensioning that starts to happen between the fingers right through there and the deep abdominal wall without holding the breath.
Keep breathing.
Yes.
Always breathing.
And then that might be where we start if people have no idea, right? Like, and the abdominal wall is offline. We start with that, just laying down and identifying that, and we translate it into function. Now, I want you to do that every time you lift a laundry basket. I want you to do that every time you lift grocery bags. I want you to do that, right, with a functional activity that's challenging them.
Yes.
And then we start to build maybe where I started, where like, okay, now let's go upright. I mean, you can do, for example, a partial squat. That's going to get overflow to your pelvic floor. We start to build into lunges. When we think about training, we train patients in 3 planes of motion that we move in. So sagittal is this way, frontal is this way, and transverse is this way. Most people will train this way in the sagittal plane.
You'll have to watch this on the video if anyone's listening on YouTube to be able to see how she's describing this.
Yes. And that's where we can start, but most of life happens, actually, believe it or not, in the transverse plane. So gait, walking, is a transverse plane motion. So that means rotation is coming in. So once we get patients to identify like, oh yeah, okay, my pelvic floor, my abdominal wall, my low back, my glutes, right, are online, they're working in concert. Let's challenge and train it in that transverse plane, which carries over to walking more efficiently. and moving, particularly, I mean, most sports too.
Okay. So let's just give a blanket statement for someone who can stand and has a reasonable strength. Stand on one leg, contract your abdominals, breathe, do it maybe 3 to 5 times.
Yep.
Hold for...
You can start by turning your head or start then, right? So hold for, again, like if I'm going to add a head rotation, like, can you do that with 10 revolutions of your head?
Okay.
Can you pretend, you're a baseball player and actually get your arms to swing across your body without losing your balance? There comes the rotation, right? Okay. So, let's do about 10 of those,
Great.
right? Or if you lose your balance, do 3 or 5. Wherever you lose it, you're done, right?
Yeah.
For
sure.
You're compensating.
And then maybe some walking lunges, because that would then incorporate movement plus the pelvic floor firing. Okay.
So we have it on our Instagram page, actually. So we show a progression where we'll do, to challenge all 3 planes of motion, like we'll do a lunge forward into sagittal plane. We'll do a lunge sideways, that's frontal.
So lateral lunges, forward lunges, all right.
And then a rotational lunge, so where it's a rotation back if we use a clock position, where if you're facing 12, you're all, I'm going to lunge facing like 4 to 5 o'clock. And then you push out of that lunge back, your pelvic floor is on. So, and that's another thing too, like with the Kegels is if it were as simple as Kegeling, guess what? Like
everybody would be fine.
Everyone would be fine.
It's more than that.
It's way more than that. And the pelvic floor gets turned on when the hip rotates, right? When forces come from the lower kinetic chain or the upper body, it's a signaling, right? Time to fire. And it's so fascinating because when do our children become potty trained?
Like 3?
After they're upright walking.
Okay,
right?
Yeah.
And that's not coincidence. It's because, right, the pelvic floor is now getting signal because the hip is rotating, internal, external, weight bearing, right? And neurologically, right, it's like, and so now they start to connect also with the brain.
They can actually hold it in.
Yeah. Versus like I have no stability. I'm all over, right? I'm not walking, right? They're wobbling all over the place because they're not, developmentally to that place yet. So, yeah.
Okay, so we've got 2 exercises that you can do in multiple different planes.
Yep.
I think that's pretty good. And then you go back to do a couple extension exercises that we talked about earlier.
And there are so many, like these are just 2 of probably hundreds upon hundreds of strengthening exercises.
Yeah, but just a good sort of thing to start with. And you can then, as you get better and stronger, you just sort of look these things up. That's the beauty of the internet. Is sort of like what lengthening exercises can we do? What strengthening exercises we can do for the pelvic floor? Yes. And make it a day. It doesn't have to take that long.
No.
It really doesn't. And even if you do 1 or 2, it's fine, right? It's just something that you practice, that you bring into your daily life, and that will help you.
Yep.
And then I think for preventing injuries as an athlete is, 1, to make sure that you're always having that extension, that extension, and that you're breathing correctly. So let's talk about the 5 things, right? You said sex, stability, supportive, sphincteric, and sun pump. So let's talk about sex. There's a myth, right, that women have loose vaginas because of sex. But you and I know that women get loose vaginas, which is not really a great term, but because their pelvic floor gets weak, right? 1 is a lot of these women are then being told or, getting other surgeries, right? To then to make things smaller, which can lead to its own problem. But what are your thoughts on that?
The surgeries or all of it?
All of it.
Okay. Yes. Number 1, I think there's so many components that come into this. Like if we really unravel, like the quote, lax vagina.
I like that a little better.
Okay.
Loose,
yes. Right.
That's a better term.
So, we want to consider was there birth trauma, right? That ever happened, right? Was there a tear that happened, right? Did anatomically the structures really change or become dysfunctional? Number 2, hormonal status, right? Mm-hmm. So because all of this influences the state of the musculature and the anatomy, right? So then if you're my age, right, and you're in your 50s, and so a lot of women will be like, oh, well, things are just now not the same, right? So they don't look the same. They're not as plump. Well, what is the hormonal status? Because the musculature, as well as like all the vulvar structures, depends on estrogen and testosterone. So if we're losing that, we need to put that back in as well.
Yes.
Right? So I would absolutely want somebody to do that before they would ever opt for some kind of surgery, because if the tissue is already lacking blood flow, dysfunctional, you go to a surgery, you're more than likely going to end up on the other side with pain.
Absolutely.
Right? So taking a step back and then really working with somebody who's skilled, physician and PT, to identify like what are all the other strategies we're going to put in to help change tissue integrity, to help change muscle and create more permanent changes by doing that versus going under the knife. I have some
horror stories.
Yes.
Yeah. So I will tell you, I see this, and this is the importance of having like a multidisciplinary team like you and I working together. I've talked about estrogen, how it affects the pelvic floor muscles on a earlier podcast. So check that out because I go into the science. But ultimately, it's really important. Sometimes, yes, you will find that there are defects in the pelvic floor that need surgery.
Correct.
But if you can work on strengthening before surgery and you can optimize the hormonal milieu, you're going to have a better outcome. And ultimately, that's the goal, is to be comfortable. And again, what is the goal, right? To enjoy pleasure, to feel good. Those are the important things for yourself. And so you have to decide if that's actually an issue or you just feel self-conscious about it. Again, that's fine to have body issues. We all do. Many people do. But ultimately figure out what your goal is and what you want it to be, because you don't want to do something that ultimately results in pain and then you're then being regretful about that treatment decision you made.
Yes. And then in some cases, surgery is warranted, for example, right? So say you have stage 4 prolapse, you have to have surgery, right? Yeah. I mean, you have to. There is pelvic floor PT is not going to be your solution. But what I love to challenge all the physicians out there and the surgeons is prehab your patients. Send them to pelvic PT first, because your outcomes are going to be that much better. And then we'll rehab them at the other end, once they're surgically cleared.
Recovered.
Yeah. So,
In terms of sex, since we're on the topic.
Yes.
People are told to do Kegels for better orgasms, to have a higher semen volume, to have just more pleasure. In a person who has a normal functioning pelvic floor, will they see benefits in terms of just optimization? Say they're normal, they're healthy, they want to optimize their sexual function. Is this a good idea?
Yeah, if the pelvic floor is normal and healthy, then absolutely. I actually always say too, particularly for women, every woman over age of 40, number one, should have a vibrator, because we're after also blood flow. And then we're after like the muscle again, once that blood flow is there, then being able to utilize that to really fire and create good force. So you have two of your pelvic floor muscles that are on the outside that go up with women to the clitoris itself. They're on the hood, okay, and they attach there. So part of their job is to help with orgasm, right? They need to be able to move through their full range of motion to also lengthen, right? So like the hood can retract back. Okay, they carry it's called the dorsal nerve. It's part of the pudendal nerve, runs up through that region. So if they, again, you don't have normal good blood flow coming in there, if they're too tight, they're not quite, or they don't go through their range and they're not strong to create compression around the dorsal vein that's also running up through there, your orgasms are going to be compromised or maybe non-existent. Yes. So yes, I think it's really great. And so, but I always love to say it's all about blood flow. So get the blood flow there first, and if you don't want to use a vibrator, whatever, cardio, anything, right? Get blood flow in through the region, and then take that muscle in through its range of motion, contract it, make sure you release it before you're going to contract it again.
Yes, there was actually a study that looked at orgasms versus pelvic floor muscle therapy, and they found that having orgasms, because an orgasm is essentially an involuntary pelvic floor muscle contraction at a rate of 0.8 seconds, or there's a cycle, right? And so it's doing it involuntarily. You don't have to actually actively contract those muscles. And so they found that in and of itself allows for strengthening of the pelvic floor muscles. So yes, I think it's great. And I always caution people that if you have any sort of pain, any sort of discomfort, stop, because there may be something else going on. You may have, assessed your pelvic floor incorrectly, and you don't want to worsen the problem.
Yes.
And then, the other thing you mentioned, how having poor blood flow and poor muscular blood flow can actually compromise orgasms. But what about when you're having dysfunction? So men will see it as erectile dysfunction. So how does your pelvic floor play a role in that?
It's the same concept, right, with men too, because we have these other muscles, the bulbospongiosis, ischiocavernous, right, that play such an intimate relationship. And so those muscles still, ideally, they need to be able to start working through their full range of motion. So it becomes like a neuromuscular response. And that's where I do like, training to take the pelvic floor, get it used to going through that range, both, if you need, if it's so offline and you're normal with the resting state, then we may need to do some other things to like wake that up a little bit. And we know, again, there's overflow from other muscles that can continue or that feed into the pelvic floor, whether male or female, whatever gender, it doesn't matter because it's the same process, right? But I always love to tell, because people are just like tight. And I'm like, but remember, lengthen before you strengthen is one of my favorite sayings. Lengthen before you strengthen, right? Even if you don't walk around with a hypertonic pelvic floor, if you had a stressful day, it might be semi-contracted that day. And so just lengthen it, right?
Yeah. So do all those lengthening exercises we talked about. And then, yes, using these exercises can benefit you. But if the muscles, what I tell people is when the muscles get too tight, they can actually compromise the blood flow to the organs. And I think that's really under-recognized, particularly in the general urology community, is that you can have erectile dysfunction because of pelvic floor dysfunction. And so I will see it very often in younger men who are, there's always like, whenever you have problems with erections, there's always a brain component because it stresses you out. It affects your thoughts and it affects your ability to focus on pleasure and focus on the actual enjoying parts of sex, because you're stressed about if your penis or your vagina is going to work the way you want it to, or your clitoris is going to work the way you want it to. So there's always that. But if your pelvic floor is tense, that can be the cause of the sexual dysfunction.
100%. A good analogy I also give patients is I'll ask them to make a fist like this. And I say, okay, look at your knuckles. What's happening with them? They're like, oh yeah, they're white. Yeah, exactly. Because there's no blood flow coming in, right? And they're short like that. So again, that you're not getting blood flow, right? And so, and anything coming through this, by the way, like if I'm a nerve, if I'm an organ right here and I'm squeezing down on you like this, is that going to be healthy? No, right? The nerve now can become compromised and it's like, oh my gosh, I'm irritated. So yes, love that.
So we talked about support. So, we talked about stability already, sort of. We talked about sex. Now let's talk about support. So we've talked, you alluded to it already, that weak pelvic floor will lead to maybe bladder leakage, will lead to pelvic organ prolapse, which is a herniation of the vagina, essentially, and the organs behind the vaginal skin that are sort of pushing down. But what about in men? How can they know they have a weak pelvic floor?
We have seen, believe it or not, with men, particularly heavy weightlifters, where they have ended up with prolapse. Sometimes because you can you see it. Of the rectum. Literally protruding out through the external anal sphincter in severe cases we've had. And I have this foreign object sensation, right? And they don't know what it is, right? And we're like, oh my gosh, right? So that's the wall, right? And now the organ that is following it down and out. So number one, if you see anything abnormal, coming from any orifice, that's not normal. Number two, a lot of patients will also feel a heaviness. So they'll walk around, they're like, oh, I feel this heaviness. They may not correlate it with their exercise or some kind of activity, but there's pressure and there's heaviness. And one of the ways I always try and figure out, like, is this related to prolapse, right? Or an organ descent, or is this actually a pelvic floor muscle problem? Because if you have a hypertonic pelvic floor, you can get heaviness too. So I'll have a patient just lay down and I have them test this at home. I'm like, when you feel that symptom, then I want you to lay down and I want you to tell me within 5 minutes, is that better, right? So when you're flat, gravity is eliminated.
So the weak pelvic floor should go away.
So if prolapse is there and you just, now you're down and flat, right? And that helps it decrease. And they're like, oh, it's so much better. Then I'm like, if it's a true muscle spasm, laying down isn't necessarily going to immediately take it down that fast.
So why are these bodybuilders getting weak pelvic floors?
Because they have intra-abdominal pressure that's exceeding what is happening down lower with the pelvic floor. So it's like that pushing or, straining if you go to the bathroom, that breath holding that's happening. Even if they're not breath holding, they don't have strategy down low to combat what is happening up higher with the heavier weights. And they have to train specifically with the whole system online and back up a little bit, work with a pelvic floor PT so that it is happening the right way, like neurologically, right? So, and in the right sequence.
Yeah. So in those cases, sometimes just breathing correctly is not enough. They'll need more.
Right. Yes.
Yeah.
So what we'll do with a lot of athletes too, like if we find dysfunction of the pelvic floor, is we will train them like in behind closed doors too. Like I will actually feel what's happening with the pelvic floor during the activity. I'm like, all right, stand up, right? Yeah. Like not everyone's comfortable doing that, but it gives us so much information and and it's functional.
Yeah.
And then we can neurologically help, right, with different techniques on getting that muscle to fire appropriately.
So say someone wants to become a bodybuilder, right? Like what can they do? Is there prevention? So we talked about breathing, right? We talked about doing lengthening exercise. What else? Is there anything else they can do?
That comes up to you utilizing, making sure that your biomechanics are right. And that is going to take like working with a professional where we're going to analyze, like say, your foot collapses, right? You're flat footed or whatever. So, and your sport requires you to be able to load in standing, right? And be able to also like push off of that effectively. Well, that flat foot, there's going to be compensation all the way up through what we call the kinetic chain, right? So the tibia, the bone in the lower leg and the femur start to rotate in, and then your pelvic floor is always cheating. So I think you've got to get a detective on your case and make the time, find somebody who has that expertise to really analyze like for you and your activity, your sport, what's happening, and then help teach you new strategy.
So sometimes it just requires you to find some help. So how does someone find a very good pelvic floor physical therapist like yourself?
Awesome question. So multiple ways. Number one, I always love to say, just Google pelvic floor PT near me.
Yeah.
Okay. And then you want to see who shows up. Number two, and then even then there's specialties within pelvic PT. So some pelvic PTs will specialize more in pre and postpartum and pregnancy. Other PTs will specialize in pain, others sexual dysfunction. Some will treat it all, some with the female athlete. So match up what your problem is with a PT that has specialty in that issue. Number two, after Google, there are different organizations. So the American Physical Therapy Association, you can find a provider if you go on apta.org. And then it's the section of, so Academy of Pelvic Health now. And then you find a provider who's a member and you just type in your zip code. There is the International Pelvic Pain Society also has a good database of pelvic PTs and MDs who deal with pelvic pain. That's pelvicpain.org. So there's pelvicrehab.com is another good database. There is my friend Tracy Scher, who started Pelvic Guru, and she has the Global Pelvic Alliance membership program of all providers across the world can register with her. So there are multiple sites. There should be no reason why, honestly, you can't find somebody. But if you live in part of the world where there isn't one, because we still don't exist everywhere yet, then find somebody that offers good telehealth. Find, somebody that you can work online with, because that's better than nothing. And there's a lot that can be accomplished that way.
So in my experience, the hard part for me as a referrer is finding a lot of pelvic floor PTs are very focused on women's health.
Yes.
And so I think that I think men's pelvic health issues are very underdiagnosed because people are not even know how to assess them. And that does require often a rectal examination. And we're not just doing a colonoscopy. We're not just doing a prostate exam. You're actually feeling for those muscles. And so it is a little bit more involved, although not that much more. It doesn't have to be that much more. So there's that part of it. But then, my patients will tell me, and I know lots of great pelvic floor physical therapists, but they'll be like, I live in XYZ because I do some telehealth, and I have a hard time parsing out people who take care of men because they'll go in, it'll be like very pink frou-frou office and they feel very uncomfortable or unwelcome.
Yes.
So do you have a good resource for them, or just what they should look for on people's websites to determine if they're, if they have experience with men?
Absolutely. First of all, just look on the website or business card or whatever if they treat men. So we put that on our business card. And we've had many men who, that's the only business card I've seen that actually says pelvic floor dysfunction for men and women, right? That is huge. Even then, you still want to interview. Just call up, we offer like discovery visits where we talk with patients for 10 minutes and tell us what you're experiencing. Are we a good match? Are we the right fit for you? So, if you're seeing a PT that you're number one, the first male, then that's probably not the ideal place for you. You want to go somewhere, although everyone has to start someplace, right? In terms of their journey. I'll never forget when I first started, I was actually at UC Irvine. So I started a program there, and I was in the department of OB-GYN because when I started, it was called the women's health, right? Literally. And I was like, but men have a pelvis too. This doesn't make sense. But APTA finally changed the name of our specialty. So I had this guy, he was my first male pudendal neuralgia patient. This was almost 22 years ago. Came in, sat with all the pregnant women, sat in the waiting room with all the women, and he didn't care because he was he called me up and he's like, are you willing to treat? I'm like, well, in full disclosure, you're going to be my first male pudendal nerve patient all those years ago. And I'm going to have my anatomy books open while I treat you. And he's like, that's fine because I can't find anyone to treat me. Yeah. So he came in, he was one of my greatest teachers, right? As I learned. So you need to interview and ask. And then really, I think once you go in, you want to make sure that you're seeing a change with your symptoms too, right? So if by about the fifth or sixth visit, the needle isn't moving at all, you might be in just the wrong hands. And there's different levels of experience across the world in the United States.
Yeah, there really is. You mentioned pudendal neuralgia. Just talk about what that is.
So that is a pelvic pain diagnosis. And I think of all the pelvic pain diagnoses that we treat, honestly, this is the toughest. It is a hard one. It's misdiagnosed a lot. It's missed a lot, under-recognized. And because it cuts across, all different aspects of functioning within the pelvis, because PN patients, most of them can't sit at all. So they can't function to drive, to eat a meal.
That's probably by the time they get to you.
Right.
By the time they get to me, maybe that too. But a little better than that, I think. Yes. Yeah. And because they're so often, you have this amazing training, so you can pick it up. Yeah. So often they're bounced around the medical system. So I'm seeing them after they've seen 6-8 different providers. And they've probably Googled it and said, I need to see a pelvic floor physical therapist, and found you.
Yes. Yeah. So the pudendal nerve is the main nerve that innervates the pelvis. There are other nerves that come down into the pelvis, particularly, from even the lumbar plexus or this lumbar spine. But this is it's a small nerve, but it is almighty and powerful. It has 3 terminal branches. One goes to the clitoris female, goes to the glans penis in the male. One goes to the perineum, and one goes to the external anal sphincter. And so pudendal neuralgia is basically an irritation of the nerve anywhere in that distribution of the pudendal nerve, right? So it gets angry. And so often, I would say 95% of the time, 98% of the time, it is rooted in a pelvic floor muscular dysfunction where those muscles are so hypertonic. Go back to this. If there's compression around the nerve as it runs anywhere through its path, right, then we start to see changes on the outside of the nerve. The sensory component of the nerve becomes compromised. You could have burning, you can have stinging, you can have numbness, you can have tingling. So anywhere that nerve travels.
Yep. Clitoris, penis. Yep. Any of those. It's pretty horrible. Let's just talk about a few of the conditions for men. So I've obviously male pelvic pain, which is a very broad umbrella topic.
Yes.
Absolutely. But what about urinary issues like post-void dribbles, one that patients always struggle with? And then we talked about sort of sexual function, but what about ejaculatory dysfunction, like premature ejaculation?
Okay. Awesome. Yeah, the post-void dribble, I think is, it's both with a lot of patients. It's present. And so I love educating patients and helping them with that, because so often, if we go back to the muscle physiology, right, and the muscle working through its full range of motion. So if the pelvic floor, when we urinate, doesn't fully elongate completely, right? And I'm the urethra, and the pelvic floor comes up and surrounds and supports the urethra and the bladder neck, right? So it's part of that supportive function. If it doesn't, we call it eccentric lengthening, if it doesn't release and allow for that pressure change to occur with the urethra, the tube we're peeing out of, the bladder neck doesn't drop down as effectively as it should, we can have a little residual urine that kind of hangs out.
Yeah.
Right. So now you get up off, if you're female and sitting, right, or whatever, if you're standing, to you shift, you move, you start walking, and then whatever residual urine is left just drips out. Mm-hmm. So with that post-void residual, it comes back to you didn't fully eliminate typically during that act of urination. So how are you going to change that from like working on voiding mechanics, helping the pelvic floor elongate better, all sorts of things. So that's that. Okay, second question was
ejaculatory dysfunction, most commonly premature ejaculation.
Yes, so that's also rooted with a pelvic muscular problem as well. Mm-hmm. So I worked with this earlier today before I drove over here for this with a patient, and this was one of his primary complaints when he came to us. Now, he's a martial artist. He had a really hypertonic pelvic floor when he first came into us, and he was able to share, like, he had one of the best episodes of sex, right? Like, his ejaculation, he's like, oh my gosh, Julie, it was so much better as those muscles now have become lengthened and go through that full range of motion. So the power, right, the force that they could generate was so much better. Now he happened to have like a weekend where he had multiple rounds of sex by like the fourth, because the muscles really kind of resorted by that time back into like, this holding pattern. Yeah. And it just, right, he's improving, but we're not quite there yet. I'm like, okay, you need to give it a break, right? Like you need, and not forever. You can have marathon weekends in the future. I'm like, but the fact that you had the first 2 to 3 really good, awesome. That's progress, because you again have now got that muscle working through its full range of motion. Blood flow comes in, right? The muscle fires more appropriately for all the things we already talked about.
Yeah. What about when you have a trauma, like a physical trauma, a car accident, any sort of injury, or even just like a labral tear, hip injury? Yes. How should people assess their pelvic floor? Because we know, right, that you can have an injury and it can disrupt the alignment, which can then affect your pelvic floor. So how can people know, like, okay, this is what's going on and this is when I need to see a pelvic floor physical therapist?
So such a good question, because trauma plays a huge role on so many levels with our patient. If there is a physical trauma, even if it hasn't happened recently, but you can track it all the way back, maybe earlier in life, even childhood, it can set the stage absolutely for pelvic floor muscular dysfunction. So for example, I had a patient that came in and female, and she was not able to consummate her marriage, right? So she had sexual dysfunction, aperuria, like inability, okay, to have penetrative sex. And so we traced it back with her where she was 7 years old. She was climbing a tree. She slipped and fell, had a split injury and landed on her perineum, because I had to cue her. She could never connect any of this, right? So with my questioning, or if you're a provider or a physician, like go back. If you're a PT, go back earlier in life. So she was like, oh yeah, so I remember doing that. And then my mom had to put me in the bathtub because I couldn't urinate for 24 hours after that fall. Falls are huge. Yeah. Whether on a tree, a bike, your hip, your tailbone, whatever, right? Like if you're a gymnast, balance beam, anything, right? So and I was like, that was the entrance point for this dysfunction back then. And so you've been building all along because, the muscles, even though you didn't walk around in pain, but they were dysfunctional. And so how do you know? You have to, again, even the patient, I'm like, let's get you to be the detective too. Any significant trauma, whether motor vehicle accident, a fall is a big one. If there is a traumatic birth that happens, if there is a complication with a surgery that was supposed to be normal and that, you came out, unfortunately, with a problem afterwards, all those are rooted, and you want to go back and then just follow the path and see, like, how has that pelvic floor compensated, and anything else that has now set up because of the original injury, and take care of that. And then we work on the brain, because right? If you perceive like, oh, no, I can't do this activity again because I'm at risk, we want to set up good, safe neurotags and firing patterns on the brain that, yeah, eventually you can.
Yeah. And same thing with emotional trauma, right? I mean, it's not the same as you've had a physical injury, but certainly it can play a huge role in the neuromechanics of that area.
Huge, so big. And that's all of these things. That's why we need a team, because I always say it's multimodal, and patients are like, what do you mean by that? Like multidisciplinarian, right? So different modes of treatment, and you have a healing team. And yes, you're going to have a few quarterbacks on that team. You know, with you as the patient, we're going to empower you to be the CEO, but everyone's going to come alongside. So we work very closely with psychologists, sex therapists, right? If there is trauma, you know, we need that addressed while we're working on the physical, 110%. Because again, if you perceive the threat, pelvic floor reacts. Yeah. So we need the medical management piece. We need the physical, or, you know, now there's occupational therapists that even specialize in pelvic health, which is awesome. And we need the psych component, the brain. Sometimes we need the gastroenterologist coming along too, right?
Yes.
So, or the orthopedic or the neurologist.
Absolutely. So what about when so you'll see, and I've seen patients where they say pelvic floor therapy didn't work for me. Why doesn't it work?
So we get that a lot. We get it in our clinic because we get patients that have kind of bounced around to other clinics and then come in. I always say, try again, because training is a little bit all over the place. There is advanced board certification you can get, just like, you know, physicians can become advanced board certified. But you really need to match up with a therapist that has true expertise with your problem, right? With your dysfunction. So don't give up. You gotta go out, get a second opinion, get a third opinion. Maybe somebody got stuck. Maybe they took you as far as they could, right? And you just need a new set of eyes. And we collaborate with a lot of therapists all over too. So don't give up, I think, is number one. Number two, like if you've seen 4 different pelvic therapists or 5, right? And you're still struggling, something's being missed. Then again, we go back to like victim or the driver. There's something out there that's driving this that hasn't been addressed. And that's, again, why we have this collaborative team approach, not just inside the clinic, but outside with our other providers, right? So then you've got to, as a patient, like go back to the drawing board and then find a specialist who understands the pelvis that might be outside of pelvic PT.
Yes.
So usually MD.
Well, I've seen some patients where they just don't respond. Like they try and try and try. They do the exercise and they just don't get it. Do you see that? We have,
particularly like with our pain population, we'll get some outliers that are really challenging cases. So again, we're helping quarterback because usually it's because there is a missing piece somewhere. And so I always tell patients, please don't give up. Even if it's beyond what we can bring, there is an answer out there somewhere, you know? And so just finding that missing piece is so critical. And so what I also tell patients is we won't give up on you either, even if I have to send you to 5 other practitioners, right? We will work with them to really figure out. I think the more we learn, again, no system works alone. And the more we're learning collectively how these systems have this beautiful interplay and dance, the better we'll be able to get our patients.
Yeah, I think it's really important. Now, a lot of people feel nervous about going to the pelvic floor physical therapist because they don't want the internal part of the exam.
Yes.
So I often tell them that very often they're not starting with the internal exam. They're usually starting with assessing your alignment, your gait, your other things. But would you agree that that's probably the way most pelvic floor physical therapists approach it?
Yes, we always follow the lead of the patient, you know, and that is different for everybody. I mean, I always say, I joke, I'm like, you know, kind of the personality and where the patient's at by how their underwear comes off. Because we have patients that will like throw it across the room to hit the chair, right? And others that are like discreetly, we step out and they're discreetly, and then they hold onto it and they tuck it behind the pillow or whatever.
Yeah.
But yes, so you follow the lead. Like I had she's 21, a young woman come in, and she actually is a female athlete, and she was referred in by her orthopedic physical therapist because she's getting sitting bone pain, low back pain that isn't responding to all the traditional orthopedic physical therapy. When we dug a little deeper, guess what? severe pain with menstruation, menstrual cramps, urinary urgency frequency, like going, 3 times during the night, which is for her age, not normal. You shouldn't be waking up. And during the day, and especially with competition and stress, she's like running to the bathroom. Like all these are classic pelvic floor. So, but she's never had a pelvic exam. She's not sexually active. So I absolutely started with all the external work, right? And we have yet to get internal because there's so much we can do externally. And then I'm going to work closely with the physician and obviously consent is huge, but we'll slowly work just even externally with the pelvic floor to bias what's happening on the inside.
Yeah.
So yes, so to calm everyone's fears so they don't freak out, right? You're in control. You're
and
in
if you
charge.
don't feel in control, find someone else.
Yes, exactly.
Yes. That's really important, right? No one should be making you feel like if you don't do this, you're not going to get better, right? Because there is so much to do, and potentially they could get better without an internal work, right?
Some people, absolutely.
Sometimes you get to the point where that would be a little better, but ultimately, if you're diligent and you work hard and you do all the external stuff, you can still get better.
And then what I find too is the more we educate and we normalize it too, and then patients get more comfortable, because I always, sometimes we say it's orthopedics in a cave, or we're like, this is just muscle. It's muscle, right? So, and then they become empowered where they're like, oh, wow. And it's this new window too for those that are comfortable.
Yes.
And we teach them how to get in there.
Super helpful. So tell me what is new in the research that either you're excited about or that patients or even clinicians need to know.
This is newer, but not super new. It's been out for a while, but it is really connecting brain and pelvis. So we call it pain science. And so understanding how pain can exist in the brain, particularly for our pelvic pain patients, right? We don't want to throw the baby out with the bathwater, because what I found is some people are like, oh, I'm just going to work on the brain. I'm like, you still got to work on the physical body too, but we're connecting. Yeah. I love, even like with functional MRIs now, we can see different brain areas that will light up, right? When we either like have a threat or perceive pain, or you're physically feeling pain. So we have something called the somatosensory homunculus, even, where all the body parts are represented on the somatosensory cortex. And so we'll start educating patients, and we're like, guess what? Your foot and your genitalia sit right next to each other up here. So they're like, really?
And your nipples and your ears.
Right? Yes.
So listen, if you guys are listening right now, check out Dr. Barry Komisarik's episode, because he talks about the homunculus and how they actually studied it and found it. It's fascinating. It's just so fascinating.
Cool,
yeah,
right?
So fascinating.
Like the neurology component,
yes,
I think is a newer area too, that that was my other love. I love neurology, because the nervous system and brain, right, is plastic, so it can change. We just have to hack into it the right way.
Yes.
So that's another one, because we'll teach patients too. We're like, by the way, I want to have better sex. We're going to go after your foot. They're like, but my pain isn't down there, right? Yeah. Or maybe they do. Maybe they actually have some irritation with the foot. Like with PN, we'll get a lot of people who have burning in their feet that also have burning in the genitalia. So like starting to hack these systems and understanding is fascinating.
So give me an example of how you're treating someone's foot.
Okay. Yes.
Yeah, that's so cool.
I love it. I love it. To understand the plantar fascia of the foot right here at the bottom of the foot is actually continuous. Like if we want to follow that up through the back of the leg, the calf, the hamstring, the fascia, which is connective tissue, right? It's our Spider-Man suit, right? 3-dimensional spiderweb-like material that lies over muscle, nerve, organ, right? So it goes up through, it's called the posterior fascial line, foot, back of the leg, up into the pelvic floor, up through the paraspinals, around the cranium, and attaches at the orbit of the eye. And that is one, we call it a fascial train. So you can yank, for example, on one part, and you're going to feel a tug in the system, or even if you don't feel it, you will influence another part. So the foot will teach patients like, okay, we want you to roll on a ball. We want you to get in there and massage it. We actually want you to strengthen. We want you to get your foot into different positions and work it, spread the toes. There are so many different things we can have the patient do, right? Use a yoga block and stretch the big toe, stretch the heel, different things like that that to hack, really even just the massaging and touching it, will change on the brain level, and we call it smudging, and spill over to the body part, the genitalia that's right next to it, okay? And when you give one area love, the other one says, thank you. I'm going to take some of that.
I love that. I love that.
Yeah, I've had patients where they'll be on the table and I'm working on the foot and they'll be like, how come my bladder urgency is going away?
Yeah.
And I'm like, right? Because you're hacking into that,
good.
right?
So
yeah, so you do that before you have sex, like you work the foot, right?
Nice. That is so cool. I did not know that. You taught me something new. Guys, if you want me to go to Dr. Sarton's office and watch a video, let me know, because we talked about doing that. I haven't done it yet. I'll release it on a Monday, but comment on this video on YouTube. If you're listening, go on YouTube and comment. If I get enough comments, we'll do it. And you can see me go through pelvic floor physical therapy, although I'm not dysfunctional, but it would still be good to just see what it's like.
Good.
Yeah, that's really cool. Is there anything else that you want to share?
No, that's just like one of many things. You know, you already mentioned earlier when we were talking like connection jaw to pelvis.
Yeah.
So we actually, with a lot of our patients too, another hack we'll use is like vagus nerve is like a new hot topic. A lot of people are talking about. So the vagus nerve is one of your cranial nerves. And so it exits between, it's the first and second cervical vertebral bodies right through here, comes down and through the neck, underneath the collarbone, under the sternum, and then comes down. It's responsible for a lot of autonomic nervous system functioning. So like respiration, how we breathe, and heart rate and digestion. But you can hack your pelvic floor by stimulating your vagus nerve and giving that love. We can create more space right here when we actually work with patients with their cranium in through here.
So when you massage the nerve itself.
So you can massage the nerve itself. It's called a suboccipital release, where we separate the cranium from C1 to create space so the nerve is like, I'm not being pinched right in.
Oh my God, I've seen some of those manipulations, and probably more aggressive ones, but they scare me. This is
gentle. This one is not like
so the one we're seeing on TikTok is not it.
No, I'm not a big fan of cracking up here at all. So this is like really, and we teach the patient, guess what you could do? You could get something called a cranial cradle, right? Just take 2 tennis balls, tie them off in a sock, lie on them right here, right? And do some gentle pelvic tilting, and you'll feel a distraction.
So
like there's all these hacks that you can do.
So cool.
And so, but that then your nervous system goes into this healthier, down-regulated state, and pelvic floor, before we've done anything down there, is like, hey.
So cool. There's a couple things I want to demystify. So one is there was a viral TikTok, like, don't pee standing up in the shower.
Oh, yes.
So let's talk about that one. Because I don't know if it was a pelvic floor physical therapist who started it. I don't remember who started it. But I was sort of like, and it went viral, and people were like, oh my God, I shouldn't pee standing up.
There was controversy, right? Because somebody said, but it is okay. And people got hammered, and a lot of emotion was swirling around all that.
So what is it? What should we do?
Okay.
Let's demystify now.
Demystify. So here's the thing, right? If you pee in the shower, you happen to be in the shower, and you do it once, like, you are not going to be subjected to pelvic floor dysfunction for the rest of your life. Like, all right,
absolutely
right?
not.
Like, no. If you have any issues with urinary urgency or frequency after running water happens, then no, please do not pee in the shower.
You're just reinforcing that.
For you. Yeah. Yes. Yeah. Right? Peeing standing up is a little, particularly like if you're a woman, right? Your pelvic floor isn't as relaxed. So, but if, you actually, if you all of a sudden need to eliminate a little bit in the shower, particularly for our patients who have like urinary hesitancy,
it can be helpful.
Retention, it can be helpful. Or another one, I actually tell patients who are like, oh, my stream is really slow. It's like a trickle, right? And I'm waiting there and I'm waiting for it to start. Remember how we talked about that full squat? I'll have them actually do it in the bathtub, believe it or not. Like on the side, like drop down into a full squat and then practice urinating in that position in the warm water sometimes. Like you can even have that. And that's, the pelvic floor is like, it relaxes, and that's nice.
Yes.
So yes. So just it's different for everybody, but
there's no blanket statements here.
There are no blanket statements. You can't say absolute black and white, like never pee in the shower, right?
It's fine. And even honestly, I think people ultimately develop this association through, I mean, everyone tells me they have to rush to the bathroom when they wash their hands or they hear water running. I mean, that is sort of an association that we've made over the course. I mean, even hearing your urine hit the toilet, right? Yes. It mimics that sound. So like, it's not a big deal, in my opinion, for most people, right? If you pee in the shower, like it's probably fine.
Right.
And the other thing is, I actually talked about this, but apparently they did a poll of men, sitting or standing to pee. And apparently, of course, in the US, the majority of men stand, but I think it was Germany where they predominantly sat to pee. And then there was like this whole uproar, like, why would you ever sit to pee? And then some people were like, well, it's better to sit to pee. Yes. So in terms of that, from a pelvic floor perspective, what do you think?
So again, I think no blanket statements. So for that individual, we figure out what works. And so, I mean, again, no nervous system is even the same. Like no pelvis is going to be exactly the same. So if there's hesitancy or retention, or you feel, we call it that post-void fullness, like, where you're like, I peed and I still feel full, or I'm running back because I got to go again. So then we start experimenting. Number one, it's so amazing for the brain to mix it up, honestly, a little bit. Yeah. It's really nice, right? Instead of doing the same thing again and again. So in those cases, I'm like, all right, well, let's see what happens. And,
yeah. And a squatty potty can help too, because again, you're getting in that same position. What I would caution against, I think you agree with this, is don't hover over the toilet.
Correct.
Like once in a while, if you have to, it's fine. Yes. But hovering over the toilet can actually be dangerous in the long term, because as you mentioned about your daughter, when you're doing that sort of hover squat, you are tensing your pelvic floor. And when you urinate, it should be relaxed.
Yes. Absolutely.
The one other thing I want to talk about is when people wake up in the morning, they're like, oh, my stream is not as strong. So why does that happen?
That's a great question. And I think that can be related to a lot of different things. So if the stream isn't super strong, we have to just dig deeper. Like, okay, why? So what position were you in when you were sleeping, right? So is the pelvic floor, first of all, like fluid load, what did you have? Is the pelvic floor on? Were you jaw clenching? Are you actually, all night? Are you a grinder? Pelvic floor is going to be on at night too. Pressure on the tailbone, pressure on the sacrum. So yeah, I think it's individualistic. There's another neuro hack I'm going to give you too for people who are like, oh, again, my stream isn't strong, or there's retention or just hesitancy. The nerve roots come from this part. They come actually from this part of the spine through the sacrum. And so you can gently stimulate with like the lightest tickle right here to get the nerve to fire. That nerve innervates the bladder. And so with our incomplete spinal cord injury patients, that's what we'll do. It's a hack to like wake up, and then patients will literally feel like, and then the urine stream will start. I've tried it myself. I have a history of a hypertonic pelvic floor too. And you can feel like it just goes back online, and then here comes the stream. So, I mean, all those, to answer your question, it's just different for each patient again. So back to detective work, like let's figure out for you right here what the problem is.
So my thought about this is that an average person who doesn't have any other problems, it's because they wake up and their bladder's so full, and so they're holding it in.
Yes.
And then when they get to the bathroom, it just takes a second to relax the pelvic floor because it's so tight from trying not to pee yourself, right? Because you slept all night and your bladder is super full if you haven't woken up in the middle of the night, and then your stream is just a little bit slower because your muscle has been so tight holding that in to then finally relax.
So, and I don't know if you've ever, but I have certainly had the dream where like in the dream, you're like, I gotta pee, right? You wake up and you're like, it wasn't just the dream, like I gotta pee, where exactly that has happened.
Yes.
So pelvic floor has been on all night, like bladder is distended, right? And then it does take so I do that little hack I just showed you when that happens.
That's a good one. That's a good one. So just tickle your back, guys. Yep. You brought a couple more models. Why don't we just show them to people? Like what? Because I think they're so interesting.
Yes. So this one is a nice model that just shows you the bony structure. And I brought this one just to show how important the structure is, particularly the tailbone, because your pelvic floor muscles attach on your tailbone, and they also attach on this bone called the sacrum. So if there is a tailbone injury from a fall, or childbirth, birth, okay, which I would say at one point, how many of us have fallen? Like 99.9%. We've all fallen at a certain point, in our life. So if this bone gets too tucked under, if this bone gets rotated, if this bone gets pulled off to the side, it changes how the muscles attach to it. So a lot of times, like when we're starting with all the external work, we're looking at like, what in the heck is the tailbone doing? It's like a keystone structure here with a ton of attachment, not just pelvic floor, but glute max comes there. There's a whole bunch of ligaments that come down here, the dural tube. So I brought this one because it moves, and part of what a good pelvic floor PT does is what the heck is happening with the bony structure of the pelvis.
Yes.
Okay.
And they'll sometimes be misaligned. So all the patients come back when they see a good physical therapist and they'll say, I'm misaligned. Like I actually have been, tilting. And so they have to work on fixing that, which will help your pelvic floor dysfunction.
Big time. Absolutely. So it's something we look at like, one side sits higher. Is it because of a scoliosis, a tight muscle coming down in through here, postural dysfunction, how you're carrying your child, 8 hours a day, whatever, right? Like the more behavioral driven. So so that's this one. Then we showed already this one because we threaded a pudendal nerve in through here. This one just has for a female, has the vulvar structures, which again, a really great pelvic PT is going to do a vulvar assessment too. Because we may be first line defense. We have direct access in California. So a patient can come in, and maybe they're coming in for their sexual pain or sexual dysfunction, and we notice that there's significant changes within the vulvar structures. We're going to refer over to you, right? Because we can only recommend, but you guys can actually prescribe, right?
Yes. I will say I love this about pelvic floor physical therapists. I just attended the International Society for the Study of Women's Sexual Health called ISWISH. Yes. And it's a multidisciplinary conference where there's not only physicians, but there's physical therapists, there's sex therapists. And this is like just one of the only conferences I've been to where it is so multidisciplinary, and we are all there for the common good of learning how to optimize our patients' sexual health.
Yes.
So cool.
I know. I love that.
It's so good. She brought this, just take a look here, this sort of crazy device, which I know what it is, but we're going to have you tell us, what is this?
What is this?
Weird-looking
Don't
thing?
be scared, right? Yes. So this is called a pelvic wand, and this gives you the ability to treat internally. So I'll train patients if a problem is more superficial towards the opening to actually use their fingers, because there's nothing like human touch. But if there's a problem with the deep pelvic floor coming in through here, I'm going to actually insert the wand. This tool allows you to get in deeper to reach areas that you could not reach yourself, to do what we call trigger point release of the pelvic floor muscles that are too tight, short, overactive, angry, right? To bring blood flow in. And it's almost like an internal acupressure. Think of that, right? So we find those areas of restriction and we can lengthen and release them to bring blood flow back in. The other side, not to completely freak out people, but you can also use this on the back side too. The skinnier side can come in through the external anal sphincter, because the pelvic floor, remember, wraps around the whole anal canal and supports the rectum and attaches here on the tailbone. So this is really nice too, obviously with some lubricant. And we do training. We do training with patients in the clinic on how they can do this, because at the end of the day, we want them the CEO. We want them to become their own therapist, right? So if they maybe got stuck on a long flight and they're like, I couldn't get up, there was turbulence, I was on a 6-hour flight and I couldn't move, and they have a history of pelvic floor dysfunction or hypertonicity, they have their wand they're traveling with, and they get off that flight, get to the hotel, boom, 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 they're going to treat.
And that's the only way for men is, right, using that pelvic wand through the
exactly,
rectum.
yes.
Okay, you don't have to, don't freak out, but it may be helpful.
It's exactly. Otherwise, too, we will teach you to use your hand. We teach partners. We do partner training all the time, which is wonderful if you have a partner. But, if you don't, then there's the wand and there's your hand.
And then you brought a vulvar pillow.
Yes. We love this one because you can see up close, like the vulvar structures. So we'll do a lot of anatomical education because so many women don't even understand their anatomy. And so
And guys, this is great for you too.
It is. Yes. Right. So yeah, just 101, anatomy 101 of the vulva. I mean, we've all seen these videos too, where they go around and they ask like, so what's the difference, right? The vulva is not the vagina, but a lot of people are confused about this. So we love looking at just, anatomy, and we teach women like, okay, this is your labia majora. This is your labia minora. By the way, right? These can become, my brain right now, a menopausal moment. They can become.
They reabsorb, you mean?
Thank you. Radial reabsorption. Yep.
I was like, I don't know where she's going with, but I think that's it.
Yep, that's it. So they can become flat. They are supposed to come down here at 6 o'clock and meet to protect something called the vulvar vestibule right inside, which is before you get into the vaginal canal and highly dependent on estrogen and testosterone. But if that has, no protection from the labia minora and you're wearing a tight pair of pants, there's friction that occurs there, right? You sit, that hurts, right? So that tissue can become inflamed for many reasons. So we do a lot of education with the women. I love this model in particular because it shows the clitoral hood, and
just like guys have foreskin, women have foreskin too.
And so we talk about what happens. You can have something called adhesions that occur right through here. And sometimes that will prevent that hood from being retracted back. And if we see that in our evaluation, again, we're getting over to our physician counterparts to have that taken care of. But lovely, particularly with when we do hormone education, because so many women, like if they are doing hormone replacement, they're just using an applicator and like squirting it up internally, and they're missing all of this amazing anatomy that benefits.
Yeah. And you can find skin conditions that are problematic,
yes,
that need assessment. And, the labia, I like to always say that they're like your fingerprint. They're different from person to person. So
yes,
sometimes they're long, sometimes they're short.
Yes.
It's all completely normal. And then I just want the fellas to take a look here. Okay. This is the urethra. This is the clitoris. Okay. And this will usually be retracted, but as the female gets closer to orgasm and gets aroused, it sort of retracts, and then you can see the clitoris more actively. And then as it gets more sensitive, the hood comes back a little bit. So just so you guys sort of know this anatomy, and the clitoris, as you should know, extends deep into the pelvis. So there's more of it that covers sort of the vagina itself. But this is a great, cute little model. Thank you for bringing it. So we end our podcast with a few questions for everybody.
Okay.
What's something you know now in life? And it doesn't have to be related. So what's something you know now in life that you wish you knew earlier?
I will say the first thing that comes to mind is take care of your health. I think when we're young, we think we're invincible. I've just gone through a major health journey myself, coming out of breast cancer, and it did stop me in my tracks. I mean, I literally had to just be still and just undergo treatment and stop everything. Thankfully, I was preventative in terms of like just going for my annual mammogram, and it was picked up. But was my diet great? No, I've cleaned it up dramatically, right? With feeding into inflammation. How do I detox? I'm compromised a little bit, so I've cleaned that up. So really, I think the younger we are and the better practices we put into play, don't assume like I'll take care of that when that happens.
Yeah.
Some people, I think we get society-wise, like we like grind and we work really hard, and sometimes sacrifice our bodies in the process.
Yes.
Don't do it. It's not worth it because, you're chasing it later. Yeah.
And at the end of the day, no one cares about you as much as you do. And there's no magic pills, guys. You've got to do the hard work. You got to eat right and go to the gym. And I know it sucks. I know it sucks so much, but the dividends will pay off.
Yeah. Absolutely.
What is a non-negotiable, something you have to do every day?
For me, I've learned to have stillness, even if it's just in between a busy clinical day between patients, so that I can breathe, so I can actually down-regulate. So the saying is, if you don't put your oxygen mask on first, you can't help whoever needs you, whether that's your children, your patients, your spouse, whatever, family, friend. So a non-negotiable now, even in light of my recent diagnosis, is to quiet down, not just the nervous system, but my mind.
Yeah, that's great. And what's something that you would share as a life hack? I know you shared so many, but a life hack or health hack?
I think one of my latest is, even through my cancer treatment now, is biohacking the body. So 2 simple things come to mind. So I've started with sauna, infrared sauna for detox, because it's so great when you sweat. It's such a wonderful way. And then this one is a little bit, I think, not off the grid, but a little bit more obscure. But I actually have started some molecular hydrogen. Oxygen is great with breathing, hydrogen too. So I'm actually doing that to help with inflammation. So
Okay, cool.
Yeah.
And then what if you could change the world with one thing, what would it be?
Well, that's a great question, because I always think legacy now that I'm in my 50s, mid 50s. So if I could change the world, I would have every single patient see at one point a pelvic floor PT, whether there is a problem or not. Like, just like, and this is not a great analogy because no one wants to go to the dentist, but like going to the dentist, right? So that we take the taboo out of it, we normalize it. It's part of your body, just like we talked about, like pelvic day for exercise, but that you check in once a year, and this is just normal. And so it spills over to all the things we talked about with the roles of the pelvic floor, right? Yeah. Everyone having better sexual functioning and all, prevention of all the other things, right? To prolapse and pee in their pants. And so, I'm fortunate that I feel like I get to do what I was created to do every single day. I would love to see that. I would love the narrative to change where it's not taboo. It's already changed, but it still has a ways to go.
Yes.
So,
well, thank you to you and many, many pelvic floor physical therapists who do a great job on social media educating the world, because it makes a difference.
It does.
It really does. Where can people find you? Where can they, if they want to see you as a patient or they want to learn more, where can they find you?
So Instagram, we are at Pelvic Healing on Instagram, and we put a lot of free content up. It's a labor of love. We spend a lot of time empowering patients with good education. If you want to go beyond that, then you can contact us through pelvichealing.com. So we're known as Pelvic Healing, but my last name is Sarton, Sarton. So Sarton Physical Therapy is the clinic name, and we're in Orange County, and we have an office. Our primary office is in Tustin, but we have a South Orange County office as well, down in Mission Viejo. And then we work with people all over the world through telehealth, and we do that, and it's just phenomenal now that we can reach people, and whether they have a PT or not, sometimes we'll work with their provider there, another PT, and do training. Sometimes it's just with the patient. Sometimes it's with their significant other. And then we have an out-of-town program where people fly in, and we have a comprehensive program where we treat them, and that can be anywhere from 3 days to, like, we've had patients stay 6 weeks, so 8 weeks even. And the last one is we now have some online courses that we're launching as well. So you can do it in self-paced, privacy of your own home. Our first one is, if you're suffering with pain with sex. So how you can be empowered to treat yourself.
Well, thank you so much. This was so wonderful, and I could have gone all night, but thank you so much. It was so good, and I'm so grateful that we did this, and I'm sure there'll be a part 2 someday soon. So
I love it. Thank you so much.
Thank you for listening to today's episode on the Rena Malik MD podcast. If you're enjoying this podcast, an easy, zero-cost way to support our podcast is by rating and reviewing this podcast on your favorite podcast platform and subscribing to our channel on YouTube. This allows us to spread free evidence-based education to more people each and every week. You can find me on social media on all platforms as Rena Malik MD, including YouTube, X, Instagram, Facebook, and TikTok. And as always, remember to take care of yourself because you're worth it.